Good afternoon, EMT students. It's Paula Johnson. We are discussing head, neck, and spinal cord injuries this evening. Just as a reminder, this is a lecture that is presented for my EMT students in my EMT course. Students are encouraged to utilize their textbooks for review, and also these presentations are based on the instruction and student textbooks from the publishers. So we will begin. National EMS Education Standard and Competencies. Of course, trauma is applying fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely injured patient. The next few slides I'm going to allow you to read, so there will be no narration with those slides. Please feel free to read, and the lecture will pick up as we move into the content. So we've got a lot of things to cover today. The big thing to remember is that the face and neck are extremely vulnerable to injury. Relatively unprotected positions on the body, they're such as in the thoracic cage, we've got the ribs to help protect the organs internally, along with the shoulders, the scapula, and the clavicle to kind of help encase and protect the structures inside. The neck is a little bit different. There's not that much there to help protect it. Soft tissue injuries and fractures are very common. And you also have to remember that you have a very large skull, the size of a bowling ball, essentially sitting on top of a toothpick. There's not a lot of structures there to help protect the cervical spine. Some injuries are life-threatening. Penetrating trauma to the neck can cause severe bleeding. Open injury may result in an air emboli. That's something that I have to impress upon my paramedic students especially. They tend to forget that an open injury to the neck, because the heart is so close to the structures of the neck, it is very easy for that much pressure to suck air into a wound. So an air embolism is really important. Whenever you're dealing with a neck injury where there is a chance that air could be sucked into it, you need to make sure you utilize an occlusive dressing. Partial or complete obstruction of the upper airway can also be the result. Several factors: blood clot from heavy facial bleeding, direct injury to the nose, mouth, larynx, and trachea, dislodgement of teeth or dentures in the throat. Severe factors: swelling that accompanies direct and indirect injury. Airway may be affected when the patient's head is turned to the side, and possible injuries to the brain and or spinal cord. Soft tissue injuries are very common. The face and neck are extremely vascular. A very small laceration can cause extreme amount of bleeding. Swelling can be more severe to these areas as well. The skin and tissues in these areas have a rich blood supply, and a blunt injury can cause a hematoma. And of course, a hematoma is a large collection of blood underneath the skin. It's a little bit worse than a bruise. Mandible injuries are common. Most of these injuries are the result of motor vehicle collisions and assaults. Signs of mandible fractures include misalignment of the teeth, numbness of the chin, and inability to open the mouth. Maxillary fractures, usually found on blunt force, high energy impacts. Massive facial swelling to the area, instability of the facial bones, misalignment of the teeth. Fractures in avulsed teeth are common following facial trauma. Kind of remind you all to consider the presentation that I gave you considering Joe Volosky and the injury that he had to his face. Patient assessment. The big thing that we have to be concerned about is with scene safety is to observe for any hazards and threats, assess for any potential violence and environmental hazards. Eye protection and face masks are standard. Carry several pairs of gloves, especially if you have more than one patient. You don't want to transfer blood off of one patient into another by keeping the same pair of gloves on. You will have to carry extra sets. And make sure you determine the number of patients. It's very easy, particularly on motor vehicle collisions. with distracting injuries, you can forget to assess the scene and make sure that you've got all the patients accounted for. Not to mention that some people will blend into a crowd. You're not sure who is really bystanders versus those that were involved in the accident. Mechanism of injury and the nature of illness, you're going to gain that by assessing the scene, and you want to consider the mechanism of injury for face and neck injuries, such as motor vehicle collisions, sports, falls, penetrating trauma, and blunt trauma. Your primary assessment is going to be focused, like every other time, on identifying and managing life-threatening concerns. If you have a problem with the face or the neck region, obviously it could impact your airway and your breathing, so it's very important to pay attention to that. You will want to perform a rapid scan and form a general impression. Look for any indicators that determine the seriousness of the patient's condition. Your injuries can be very obvious, or they could actually be hidden. When you're forming that general impression, you want to control any blood loss that you note with direct pressure. Consider the need for manual stabilization of the spine, and always check for your responsiveness using the AVPU scale. Airway and breathing. Ensure you've got a clear and patent airway. If they're unresponsive, consider a properly sized oropharyngeal airway. Of course, if they have a gag reflex, this is not going to be a possibility. But again, remember, if you're dealing with a head trauma, you will not want to utilize a nasopharyngeal airway for fear that if there is damage to the bones inside the nasal cavity, you could accidentally place the nasopharyngeal airway into the brain tissue. So you want to refrain from using an NPA and only utilize an oropharyngeal airway. Palpate the chest wall for any decap BTLS. Deformities, contusions, abrasions, punctures, burns, tenderness, laceration, and swelling. Face and throat injuries increase the need for airway and breathing maintenance. We've kind of said that already, just hitting that point again. When you get to the point in your primary assessment where you're looking at circulation, make sure you not only assess your pulse rate, rhythm, and quality, but remember, skin condition, color, and temperature can provide you with a great deal of information on the patient's perfusion status. Check your capillary refill time. Just remember that cap refill time is not always accurate in adults. So if you notice any significant bleeding, it is considered an immediate life. Your transport decision, any patient that has a problem that is impacting the airway or their breathing, or if they have significant bleeding, should be an immediate transported as a threat to life. So those people will be, you'll do most of your work with those patients in the back of your truck as you're moving down the road once you get them immobilized and stable. And you will want to do your reassessments every 5 minutes. Also, it's really important to keep a high index of suspicion that a patient who has suffered a severe mechanism of injury might have a severe internal bleed somewhere. So any patient that you suspect to have internal bleeding, they must be transported quickly, and their treatment is going to be getting them into that surgical suite. Remember, trauma is in fact a surgical disease, so it requires us getting them from the point of impact to the surgical suite, and it's called the golden hour when it's based from the time that the injury occurred until the time they get into the surgical suite should be less than an hour. Anytime you have a patient who has signs of hypoperfusion, if you remember, hypo means low, perfusion has to do with perfusion, so they have low perfusion, they will have tachycardia, they'll have an increase in their heart rate, they're trying to maintain the container. Remember, we always talk about the vascular system being nothing more than a container, and they have to keep the container full, so they're going to have tachycardia. They're going to have tachypnea. Tachy means fast, pnea having to do with breathing, so they're going to have an increased breathing rate. They'll have a low blood pressure, but remember that low blood pressure is a late sign. You may not see a low blood pressure initially. Weak pulse, cool, moist, pale skin. Even if the patient has no signs of hypoperfusion, there is a possibility of eye injuries. The patient should also be transported rapidly if they have an eye injury. Surgery will be needed to be accomplished, and they say within 30 minutes. That number varies based on textbook, but if they do not get into that surgical suite within 30 minutes, then they may have permanent bleeding. When you're doing your history taking component, you want to investigate the chief complaint. You will need to obtain a medical history. The reason being, some of your medical patients with their already pre-existing illnesses can have an impact upon their current situation. If you have someone who has suffered a blow to the chest wall, for example, in a motor vehicle collision, but they also have a history of COPD, then their symptoms will present worse than it would if it was you or I without that pre-existing illness. Also pay very close attention to the medications they're on. We've talked in class about beta blockers before. Remember, beta blockers prevent the dilation. That actually prohibits the tachycardia you would see in hypoperfusion. So you may have a patient who's severely ill that you don't note the tachycardia in because the beta blockers are preventing the increase in the heart rate. So it's really important to kind of keep that in the back of your head. Medications can also impact how the patient is presenting to you. They may be seriously ill and you be unaware of it. Be aware of any pertinent negatives. Remember, that's, for example, you would expect someone who is complaining of chest pain to also have associated shortness of breath with it. If they're not complaining of shortness of breath, then that is considered a pertinent negative. Gather a sample history from the patient or from family and friends. When you get to the secondary assessment and the physical exam, if multiple symptoms have been affected, start with a full body scan. Do not delay transport to complete a thorough physical exam. You can always do that in the back of your ambulance on the way to the hospital. Focus on the isolated injury, the patient's complaint, and the body region that's being affected. Ensure that control of bleeding is maintained and note injury location. You will need to parlay that information to your receiving facility. Inspect the open wound for any foreign material or impaled object. Use both your eyes and your hands. It's always important with your trauma patients especially that you not only inspect, but you palpate and auscultate as well. And assess all underlying cysts that may be included. When evaluating the eyes, start with the outer aspect and work toward the pupils. Look for any discoloration or clarity of vision, any bleeding noted or redness. Look at the eye symmetry and the pupillary size and the reaction to light. Your brain injuries, nerve disease, glaucoma, and meningitis are the causes of unequal pupils. And just to kind of give you a little hint of the importance is we've had medical physicians at the receiving facility receive a report from crews that have said, oh, their pupils were pearl, and went on about their day. And unfortunately, the medical director calls them back in, says, how is this patient having pupillary symptoms that are considered pearl because they have a glass eye? So never get caught like that. It's not good. It makes you look unprofessional and sloppy. Always do a thorough assessment, and if you don't investigate it, don't say that you have. Vital signs, you assess your vital signs in order to obtain a baseline, and then you're going to be looking for any trending as you reassess every 5 minutes. You may be concerned with visible bleeding and any unseen bleeding inside the body cavities. With your facial and throat injuries, baseline information is very important. That gives you an indicator as if their breathing status is maintained. Use appropriate monitoring devices. With your reassessment, you repeat your primary assessment. You're reassessing the vital signs, looking for any trending. Again, that's done over every 5 minutes. Your interventions, you want to make sure that everything you've done up to this point is still being maintained and that there's no issues. You also want to make sure that you address anything that you didn't have time on scene to do. Remember, you can do a full body immobilization to the backboard and then once you get in the truck, handleize the immobilization of those isolated injuries, say to the forearm, for example, if they had a broken arm. Once you've immobilized them entirely to the backboard, that's considered enough until you get in the back of the truck, when you have the time where you can actually sit down and do the interventions as time permits. Make sure you maintain an open airway and be prepared to suction. Patients who suffer facial and head injuries may not only have nausea and vomiting that are associated, that you have to be very aware of and be prepared for, but remember that bleeding can enter into the oral cavity and can cause its own airway obstruction, so it's really kind of important to have that suction there and prepared to take care of managing any bleeding. And any time you suspect that someone has significant bleeding, whether it be internal or external bleeding, go ahead and provide them with high flow oxygen and control any visible bleeding that you may have. When you're doing your reassessment, make sure that you treat for shock. If you note that your patient is hypoperfused, they have hypotension, tachycardia, all those signs that indicate shock, it's important that you maintain body temperature, keep them warm, give them oxygen, and keep reassessing them frequently. It's also important to go ahead and call for advanced life support or your ALS provider, your paramedic or intermediate, to come out and assist you. Communication and documentation. Include a description of the mechanism of injury, and remember that can be pretty in-depth. And you also want to note the position in which you found your patient and document the method used to remove the patient from the vehicle. If they had to utilize the jaws of life in order to cut the car for you to be able to access the patient to get them out, then that's something that also needs to be documented. And you may also want to include the time it took for that extrication or extraction of the patient from the vehicle. You want to include the time that it took for that extrication to be completed in your documentation. Recognize, estimate, and report the amount of blood loss. We talked about that in last week's class. Use something that you're familiar with. Your pop bottles. Everybody has the idea of the amount that's in a pop bottle. It's about 500 milliliters, 600 milliliters. That's a good way for you to kind of document how much blood do I see, will it fill a pop bottle, and then just keep adding that together. That's something that you can use. And inform the hospital about all injuries involving the head and neck. That way they can have the proper people there available to start care on that patient the minute you roll in their doors. I'm going to look at soft tissue injury. Treat your soft tissue injuries to the face and neck the same as you would anywhere else. You assess your ABCs, and the life threats always come first. Make sure that you have an open and patent clear airway. Avoid movement of the neck in a patient who has cervical spine injuries. Control bleeding by applying direct pressure with a dry sterile dressing. You can use roller gauze wrapped around the head to hold a pressure dressing in place. Just remember, if it's bleeding from the neck, you need to have an occlusive dressing that you use. And you also do not want to wrap all the way around the neck, because that can occlude blood flow going to the brain. Do not apply excessive pressure if there's any underlying skull fracture suspected. If it feels crunchy underneath your fingers, then that's definitely not an injury you want to keep pushing on. Apply ice locally to injuries that do not break the skin. And if you've got soft tissue injuries around the mouth, check for bleeding inside or broken teeth, tongue lacerations. They can cause just as extensive bleeding as facial lacerations. And that can also cause obstruction to the airway, so we have to make sure we maintain that. Physicians can sometimes graft a piece of avulsed skin back into position, so it's always important for you to kind of gather anything that you may find, wrap it in sterile dressing, place it in a plastic bag. You're going to keep it cool, but don't place it directly on ice, because you can damage the tissue if it is directly on ice. Make sure you label and deliver it to the emergency department. The same goes for digits, Anything that may be ripped off traumatically can be placed in sterile dressing, put in a plastic bag, and then that plastic bag is immersed in something cool, not ice. And then that will help protect the tissue. Maybe it can get grafted back into place. If it is a piece of avulsed skin that is still attached to the arm or extremity, place the flap back into the position as close to normal as possible and hold that in place with a dry, sterile dressing. Eye injuries are common, particularly in sports, and they can produce lifelong complications, including blindness. In a normal, uninjured eye, the entire circle of the iris is visible. The pupils are round and typically equal in size and reactive to light equally. After an injury, pupil reaction or shape and eye movement can be disturbed. So your treatment is always going to start with a thorough exam using your typical precautions. And you want to make sure that you personally don't cause any more damage to that. So you're not going to aggravate any current problems. Look for abnormalities or conditions that may suggest the nature of the injury. Foreign objects. We talked about these in class last week. Just to bring it up again, even a small object can bring on significant damage. Irrigation with sterile saline solution is going to flush away any loose particles or debris. You can use a bulb syringe. That nasal airway or nasal cannula, that nasal cannula would be a good thing to utilize. We talked about that in class. Always flush from the nose outward. That keeps the fluid from puddling and perhaps getting into the unaffected eye. And here is a good pictorial representation of using the nasal cannula as a drainage unit for the eyes. If it is a chemical that's been introduced into the eyes, something else you want to do is make sure that you have plenty of gauze that catches the drain off or the runoff that you see in this picture. That way that chemical doesn't cause damage to other skin tissues. A foreign body will leave a small abrasion on the surface of the eye. Irrigation may not wash out foreign bodies stuck to the cornea or lying under the upper eye. They may be impaled. If that happens, not only do you bandage the object in place to support it, but you want to cover the opposing eye as well. Cover them both. Surround the object with a donut-shaped collar, something that's going to help stabilize it and keep it in one solid place. Burns to the eye. Your goal with any burn, whether it's burns to the eye or burns to the skin, you want to stop the burning process. If you stop the burning process, that's going to prevent further damage. So make sure you stop the burning process. Chemical burns, acid and alkalis, make sure you flush the eyes with water or saline. A lot of textbooks will tell you that you want to flush them for a minimum of 20 minutes in order to make sure that you get all of the chemical out. Here's some examples of different methods to flush the eye. You do have to keep the eye open. That's very difficult for someone who has suffered traumatic injury to their eye or some sort of chemical or something that's in their eye. Their body's natural reaction is to shut the eye, so you kind of have to maintain or force the eye to stay open so that you can actually flush it. There's also a thing called a Morgan lens. That is something that is becoming more commonplace. It kind of looks like a contact lens that has a tube attached to it, and you're actually flushing straight into the eye with the contact, that Morgan's lens, that contact lens looking object. Thermal burns. During a fire, the eyes will close to protect themselves from heat. The eyelids will have a tendency to burn. Always pay very close attention to people who have singed eyebrows or singed hairs on their eyes. Transport promptly without further exam. You want to cover both eyes with sterile dressing. You can moisten It's one of the few times in a thermal burn where you can actually moisten, as if you have a certain amount of percentage burn to the body. But the eyes is one thing that you can use a sterile dressing that's been moistened. And apply your eye shields over the dressing. Light burns, infrared rays, eclipse light, laser beams can all cause significant damage. Retinal injuries caused by exposure to light are generally not painful but can result in permanent damage. Severe conjunctivitis usually develops with redness, swelling, and excessive tears. Lacerations require very careful repair in order to restore complete appearance and function. Bleeding can be heavy with lacerations, but it can be controlled with gentle manual pressure, and I do want to enhance the word gentle here. If there's a laceration to the globe itself, apply no pressure to the eye. Laceration to the globe itself, apply no pressure to the eye. Never exert pressure on the injured globe. We're going to hit that again. If part of the eyeball is exposed, gently wrap it in a moist, sterile dressing, and that kind of keeps the lubrication to it to prevent it from drying out. Cover the injured eye with a protective metal shield, eye cup, or sterile dressing. On rare occasions, the eyeball can become displaced from its socket. You do not attempt to reposition it. Cover the eye again with that moist, sterile dressing. Stabilize it so that it doesn't roll around where it shouldn't. And cover both eyes, because remember, your eyes will want to move in unison, and have the person lay supine. Blunt trauma injury ranges to from the ordinary black eye to a severely damaged globe. Hyphema. Hyphema is bleeding that obscures all or part of the iris. It's not your bloodshot eyes. It's actual blood that sits in the iris. An orbital fracture is a fracture of the bones that house or encase the eye floor and support the globe. And sometimes retinal detachment is seen in sports activities. If you see any of the following signs, it is good to have in the back of your head that this person has suffered high index of suspicion for a head injury. So if you see one pupil that's larger than the other, or if the eyes are not moving together in unison, failure of the eyes to follow your finger, bleeding under the conjunctiva, protrusion or bulging of the eye. In blast injuries, signs and symptoms range from severe pain and loss of vision to foreign bodies within the globe. If there's a foreign body, do not remove it. Do the same thing you did before, where you're going to pad around that object, that foreign body, and protect it so that it doesn't continue to damage the eye. And then you also want to cover the other eye as well. That way they don't try to move in unison and cause more damage. If the patient has severe swelling, do not force the eyelid open to examine. Contact lenses. Do not remove a contact lens unless you have a chemical burn. To remove hard contact lenses, they tell you to utilize a small suction cup. If you're going to remove soft contact lenses, place 1 or 2 drops of saline in the eye, pinch it between your thumb and index finger and lift, and I believe the next slide actually shows that, and I'll let you kind of review it. Doesn't do a real good picture of showing you how to pinch it, but just know to pinch it. If you've got friends that have contact lenses, have them show you how they take them out. That's a good way to do it. Nosebleeds. The medical term for nosebleeds is epistaxis. That's something you'll see on National Registry exam probably, is epistaxis. Know that that is a nosebleed. Typically the most common cause is digital trauma. We've stuck fingers in places they don't belong, and we've picked things we shouldn't pick, and now we've caused bleeding. Anterior nosebleeds usually originate from the area of the septum. They bleed slowly. Posterior nosebleeds are typically more severe. They cause the blood to drain to the back of the throat. Nose often takes the brunt of physical assaults and car crashes. Blunt injuries can be associated with fractures, soft tissue injuries of the face, head, neck, cervical injury. This is a good picture to kind of give you an idea of how the nose is structured internally. Of course, you've got the septum that divides it into a right and left, but you'll also see how thin that bone is between the nasal cavity and the skull cavity. That is often the site of the fractures that the nasopharyngeal airway shouldn't be placed in there with the head injuries, because it can go straight up into the brain cavity as opposed to down the nasal cavity like it's supposed to. The turbinates you see there are responsible for warming and humidifying air as it comes in. Cerebral spinal fluid can escape down through the nose if you have a fracture at the base of the skull. So always make sure you control bleeding by applying a sterile dressing. And we've talked about the cerebral spinal fluid before. If you take a drop of that blood and place it on a 2x2, it will have a halo or a little haze, a clear haze around the ring of it. And that is a good indicator that you have cerebral spinal fluid involved. And just remember that that's your body's way of trying to compensate for shifts in pressure. So don't try to pack the nose. Ear is also very, very associated with head injuries as well. You can have cerebral spinal fluid that can leak from the ear. It's very complex. It's not only associated with hearing, but we also have our sense of balance, and it's divided into three parts: an outer ear, a middle ear, and an... This is a nice little pictorial representation. You can see the outer ear that extends from the pinna all the way to that tympanic membrane where the middle ear begins, and the inner ear is where you find that cochlea. Ears are often injured, but they do not bleed very much. In the case of an ear avulsion, wrap the avulsed part in moist sterile dressing and place it in a plastic bag. Children place foreign objects in their outer ears all the time, so that's another thing that you may encounter periodically. Clear fluid coming from the ears, again, cerebral spinal fluid, can indicate a skull fracture. Facial fractures typically result from blunt trauma. Assume a direct blow to the mouth or nose has caused facial fracture. Other clues include bleeding in the mouth, inability to swallow or talk, absent or loose teeth, or loose or movable bone fragments. Facial fractures alone are not acute emergencies unless there is serious bleeding. Your plastic surgeons can repair the damage to the face and mouth if if the injuries are treated within 7 to 10 days. Swelling can be extreme within the first 24 hours. That's why they don't attempt to do any surgical intervention at that time. That's not necessary because the swelling can be a problem all on its own. Dental injuries can be traumatic to the patient. Bleeding will occur whether the tooth is violently displaced. Bleeding will occur whenever a tooth is violently displaced from its socket. Apply direct pressure to stop the bleeding and perform any suction as needed. Cracked or loose teeth are responsible for airway obstructions. Save and transport your avulsed tooth. Now, they used to have different theories about how a tooth should be handled in the field. They used to say use cold milk, place the tooth in cold milk. More of what you will see now is the sterile saline, even though cold milk is still considered an option. But sterile saline, I believe, is what you're going to see on National Registry. Notify your hospital. They can typically reimplant the tooth if it's within 20 minutes to 1 hour after the trauma has occurred. Injuries to the cheek. If you are unable to control bleeding, that's when you consider removing the object. You're going to have to move it in the direction of travel, so you're not going to back it out. We talked about this the other day. You're not going to back it out. You're going to have to follow the path through. Then provide direct pressure on the inside and outside of the cheek, and the amount of bandaging should not occlude the mouth. You want to make sure that you're maintaining that open airway. Going back to talking about the neck, there's lots of structures that are vulnerable to blunt injury or blunt trauma. The upper airway itself, the esophagus, the carotid arteries and the jugular veins, the thyroid cartilage, the cricoid cartilage. All of these are structures that are so unprotected, but they're absolutely vital to our survival. We have to have them in place in order to maintain an open airway and a patent direction of flow for air, so we have to have it for breathing. Blunt injury, you may have a crushing injury of the upper part of the neck involving the larynx and the trachea. Once the cartilages of the upper airway and the larynx are fractured, they do not spring back to their normal position. You can squeeze and they'll return, they'll kind of recoil back, but once they've been fractured, they won't go back to their normal position. That's going to cause a problem with airway patch. It can lead to loss of voice, difficulty swallowing, severe and sometimes fatal airway obstruction, as I mentioned in the previous slide, leakage of air into soft tissues. If you have leakage of air into the soft tissue, into the actual skin, it will create a condition that's called subcutaneous emphysema, and it's almost like a bubble wrap. And everybody knows what it's like to play with bubble wrap. Kids love to sit there and pop them. But it gives you a bubble wrap appearance under the skin. It's actually where air enters into that tissue and it causes that bubble wrap, that crackling sensation. Once you see it, you will. You can also have penetrating injuries to the neck that cause profuse bleeding from a laceration. Again, remember to use an occlusive dressing along with the other things necessary to maintain or stop the bleeding from that area. Injuries to the carotid and the jugular veins can cause what they call mass exsanguination. Exsanguination is the fancy medical term that means a mass bleed out. Typically, if they're going to have mass exsanguination to the point that by the time you get to the scene, that patient has probably already expired at this point. Blunt force trauma to the larynx can occur if you have an unrestrained driver that strikes the steering wheel, or if a snowmobile rider strikes a clothesline, and it's called a clothesline injury. The larynx becomes crushed against the cervical spine. That gives you soft tissue injury along with fractures. They'll have swelling, could be separation of the penetrating or impaled objects in the larynx should not be removed unless they interfere with CPR. You always want to stabilize the impaled object if they are not obstructing the airway. And you may be thinking, well, that's great, but how am I going to put a C-spine or a C-collar on this patient to maintain their cervical spine? In this case, you're probably going to have to use a towel roll, and we will explore that in class. You'll get to practice that skill. But you may have to use a towel roll to help maintain the cervical spine. And in that way, you can also use that to do double duty and stabilize that impaled object. Signs and symptoms of larynx injuries: respiratory distress. They may have hoarseness, pain, difficulty in swallowing. The term for difficulty in swallowing is dysphagia. Dys means difficulty, phagia having to do with swallowing. Very different from dysphasia with an S. That has to do with speaking. Cyanosis. They'll have pale skin. Sputum in the wound. Again, that subcutaneous emphysema, that bubble wrap, crunkly, crackly feeling. Bruising on the neck. Maybe they have a mass hematoma. Now remember, that's a little bit more than just a bruise. You have a large collection of blood underneath the skin. A bruise, the technical term for a bruise is ecchymosis. Hematoma is more than that. As with everything, you make sure that you provide your patient with oxygen and ventilation, supply them with some sort of cervical immobilization, and always, it's a good idea to call for a paramedic on these calls. Spinal cord injuries. The nervous system is a complex network of nerve cells that enable all parts of the body to function. It includes the brain, the spinal cord, and lots of nerve fibers that travel. Nervous system, though, is well protected. The brain is protected by the skull, whereas the spinal cord is protected by the spinal canal within the vertebrae. Despite the protection, serious injuries can damage traumatic insult to the head that may result in injury to soft tissue and bony structures or the brain. 52,000 deaths occur annually in the U.S. as a result of head injuries, account for more than half of all traumatic deaths. When you consider a head injury, it's similar to other things. It's either a closed injury, because the brain has been injured but there's no opening to the brain tissue, or it's an open injury where you have an opening from the brain to the world outside, often caused by penetrating trauma, maybe bleeding and exposed brain tissue. Motor vehicle collisions are the most common mechanism of injury for head injuries. They may also occur when you have a patient who has suffered assault, or if you have an elderly person that has fell. We've talked before in lifespan development how as you age, your geriatric population, they start to have things slow down and things get more atrophied. And your brain is one of those things that will lose some of its mass and will get a little bit smaller. And that allows for the brain to be able to move around easier within the skull itself. And when your elderly patient falls, they can actually have that coup contre coup injury in the brain, where that brain tissue bounces off the skull on one side and then bounces off the opposite side as well. During sports-related injuries, and in a variety of incidents involving children, kids are exploring their environment and they have a tendency to get hurt at times. Any head injury is potentially serious regardless. This is a nice little picture to kind of show you the general signs and symptoms of a head injury. I'm not going to read it to you. I'm just going to let you peruse it. We've talked about it before. Scalp lacerations can be minor or serious. Just remember that because our face is highly vascular, it's easy for even small lacerations to lead to significant bleeding. The blood loss can be severe enough to cause hypovolemic shock. Hypo meaning low, vol meaning volume, emic or emia having to do with blood, so low blood volume, and it's a type of shock. They are often an indicator of deeper, more serious injuries. Significant force applied to the head can cause a skull fracture, may be open or closed depending on whether there is an overlying laceration of the scalp. Injuries from bullets or other penetrating weapons will often result in skull fractures. Signs of a skull fracture include the patient's head appears deformed. Maybe there's visible cracks in the skull, or ecchymosis, again that's that fancy medical term for a bruise, that develops under the eyes, and that condition is called raccoon eyes. We've mentioned that in class before. Ecchymosis that develops behind one ear over the mastoid process, those are called battle signs, and that's the bruising that's behind the ear, another thing we discussed in class last week. These are some examples of that raccoon eyes and then the battle sign. Linear skull fractures. These account for about 80% of all skull fractures. Radiographs are often required in order to be able to see these because they have no outward physical sign. They're usually just a nice flat linear fracture. This is an example of a compressed skull fracture. High energy, direct trauma to the head with a blunt object. I always use the baseball bat to the head kind of theory there. But frontal and parietal bones are the most susceptible. The bony fragments may be driven into the brain tissue, so it's really important that we don't further damage it. Use light pressure dressings. Do not do direct pressure where you're forcing the tissues down further in. A basilar skull fracture, these are associated with high energy trauma, usually occur following diffuse impact to the head, and these are the ones that have the cerebral spinal fluid that drains from the ears. They have the raccoon eyes, and the battle signs behind the ears. Open skull fractures. Whenever there's severe forces that are applied to the head, and that's often associated with trauma to multiple body systems, the brain tissue may be exposed to the environment. This can be very distracting. It can be very distressing to the new EMT. Just remember that you need to cover it and continue on with the treatment of your patient. Protect it from the environment. Traumatic brain injuries are considered the worst of all head injuries. There's two broad categories. There's called a primary or a direct injury, and then a secondary or indirect injury. Your primary brain injury results instantaneously from the impact of the head, whereas your secondary brain injuries, or that indirect injury, increases the severity of the primary injury. So that's kind of silly there, but if you consider your primary brain injury, that's the direct impact to the head. The indirect may be the swelling, the tissue swelling that comes as a result of that direct impact. Then you have the swelling, the tissue swelling. That can add or increase the severity of the primary injury itself. Another example here with your secondary injuries or your indirect may be hypoxia, lack of oxygen, hypotension, low blood pressure, cerebral edema, as we mentioned, intracranial hemorrhage. So you have hemorrhage that is occurring within the brain tissue itself, within the cranial cavity itself. You have blood. Increased intracranial pressure, that can be the result of increased fluid or pressure to the brain tissue, and ischemia, where it's going without oxygen. Infection can also cause more secondary injuries to occur. The brain can be injured directly by penetrating object or indirectly as a result of external forces. And we've talked before, and we mentioned it earlier in this presentation, about coup contra coup, and its result commonly with a motor vehicle collision where they strike a windshield, for example. Geriatric patients, when they fall, may also experience it. But the initial impact injures the front part of the brain. If you can imagine striking a windshield, the first part of your frontal region of the brain is going to be the first thing to hit the windshield. So that front part of the brain is the initial impact. And as the head falls back against the headrest, then you're going to have the brain tissue that impacts the rear portion of the skull. So that's where that coup and contra coup. Accumulations within the blood or swelling of the brain can lead to an increase in intracranial pressure. That's what ICP stands for, is intracranial pressure. Increased ICP squeezes the brain against the bony prominences within the skull itself. If you remember, we talked about taking the skull cap off, removing the brain tissue, looking down inside. The bottom of the brain is not smooth. It's got a lot of ridges. And it forces, if you have intracranial pressure, it will force the brain tissue down on those ridges and will force it through the opening for the cervical cord, the spinal cord, where it comes in to the brain tissue. It will force the brain tissue to kind of herniate through the foramen magnum, and remember that's the hole at the base of the brain, or excuse me, the base of the skull that allows for the spinal cord to come through. These are some examples of the levels of intracranial pressure. Remember that as that brain gets pressed through the foramen magnum, you will initially see the patient present with decorticate posturing, where they're pulling toward the core. As it continues and gets worse, you see them start to have the decerebate posturing, where they're no longer protecting their core. That indicates their condition is worse. Bleeding inside the skull will increase the intracranial pressure. Bleeding can occur between the skull and what's called the dura mater, beneath the dura mater but outside the brain, or within the tissue of the brain itself. Remember, if it's above the dura, it's considered an epidural bleed, and it's arterial in nature. whereas a subdural bleed, where it occurs below the dura, is a subdural bleed is venous. And here's a good picture. The the epidural hematoma, where you have the accumulation of blood between the skull and the dura mater, it's a result to the head, a blow to the head, that creates that fracture. Typically, the associated injury is in the temporal region and involves that middle meningeal artery, and that is something that you need to know. Occasionally that comes up. Students come back and tell me that they saw it on national registry testing, where it talks about the epidural bleeds being arterial in nature and involving a blow to the temporal region where that middle meningeal artery travels. With a subdural hematoma, these are your venous bleeds, and it's accumulation of blood beneath the dura mater, but outside of the brain. It occurs after falls or injuries involving strong deceleration forces. With your subdural bleeds, your venous bleeds, a good example is you're town drunk. You become complacent because, oh, we're just picking him up. He's stumbling around the town again. He's just drunk. We're going to take him to the hospital and be done with him. Or you may do that horrible, atrocious act of getting a no transport signed on that patient. That's very bad because if you become complacent and you don't realize that, yes, he may have been drunk 3 days earlier and he fell and caused himself to suffer a subdural hematoma, those signs of a subdural hematoma may not appear for a few days. So you may see them with the ataxia, where they're not able to ambulate properly. They kind of stumble around. You may see them with an altered mental status. All these are signs that they have suffered a subdural hematoma, but in addition to that, they can mimic his alcoholism. So if you become complacent and you get a refusal, or if you just do not care for that patient properly, you may miss that subdural hematoma and further damage your patient or cause death. So it's really important to kind of keep that in the back of your head. Now, with an epidural bleed, because it is arterial in nature, the signs of an epidural bleed occur very quickly. That arterial bleed, arteries bleed quickly. Venous bleeds are slower. So an arterial bleed, you'll see those signs show up very quickly, whereas a subdural bleed may take a few days. Intracerebral hemorrhage, intra meaning within the cerebrum. This is bleeding within the brain tissue itself. It can occur following a penetrating injury to the head or because of those rapid deceleration forces. Subarachnoid hemorrhage. This occurs in the subarachnoid space. And we reviewed the layers of the dura mater in class. I asked you to review that or look at the pictures in your textbook to review that information. That subarachnoid space is the location of where your cerebral spinal fluid circulates. If you have a subarachnoid hemorrhage, you're going to have bloody cerebral spinal fluid. They may have meningeal irritation. Common causes include trauma or rupture of an aneurysm. A concussion is a blow to the head or face that causes concussion of the brain. Closed injury with temporary loss or alteration of part or all of the brain's ability to function. About 90% of patients do not experience a loss of consciousness with a concussion either. That's a common misnomer. Everybody thinks, oh, they suffered a concussion, they're going to be knocked out. Not always. A patient with a concussion may be confused or have amnesia. Usually a concussion lasts only a short time. You always want to ask them if they have any symptoms like dizziness or weakness and keep a high index of suspicion that they've suffered a concussion. Ask if they have any visual changes. Nausea and vomiting, of course, we know that comes with everything. Ringing in the ears, slurred speech, inability to focus, lack of coordination. Delay of motor functions, inappropriate emotional responses, temporary headache, or disorientation. A contusion is far more serious than a concussion. It involves physical injury to the brain tissue. And people who have suffered a contusion can sustain long-lasting and even permanent damage. They may exhibit any or all of the signs of typical brain injury that we've already discussed. They can arise from medical conditions such as blood clots or hemorrhages. Non-traumatic injuries are often the same as those of traumatic brain injury, except that there's no obvious history or any external evidence of trauma. Spine injuries can be compression injuries from a fall. Motor vehicle crashes, they can either overextend, flex, or rotate the spine. We've talked about the methods of travel in class where they can do the up and over path or the down and under. And if they take the up and over path, it can overextend or cause compression to the spine. And it can be pulled along its length. It's called a distraction injury, such as in the case of someone who has decided to hang themselves. A hanging is considered a distraction injury to the spine because you're pulling it along its length. Subluxation occurs when the vertebrae are no longer aligned. Always suspect a possible head or spinal injury if you have someone who has a motor vehicle collision. If it's a pedestrian versus motor vehicle, they always say consider the number of wheels that something has attached to it, and then that's going to tell you how much the damage could be. They say someone who's on a bicycle facing off against a car because the car has more wheels is more likely to cause more damage to the bicycle, for example. But a pedestrian who has no wheels at all against motor vehicle collision is going to suffer possible head and spinal injuries. Falls, particularly falls that are 3 times the patient's height. It's very important, 3 times the patient's height. Blunt trauma, penetrating trauma to the head, neck, back, or torso. Motorcycle crashes. Motorcycle crashes, they always take the up and over path, or they may lay the motorcycle on its side. Either way, it can cause damage to the head and spinal cord. Rapid deceleration injuries, hangings, diving accidents where they've dove into a shallow end of a pool and they may have hyperextended their neck, broke their neck. Recreational accidents. Every time you enter upon a scene, evaluate it for any hazards that pose a problem for you or your bystanders or your teammates. Be prepared with appropriate standard precautions, including gloves, mask, and eye protection. And it's a good idea to call for ALS intervention as soon as possible. When assessing a patient with possible closed head injury, consider the mechanism of injury. Did they fall? Was he in an automobile crash? Was the patient the victim of an assault? If they were involved in an automobile crash, did they have any safety restraints? Did they have their seatbelt attached? Did they have airbag deployment? And always remember with airbag deployment, and I think I've mentioned this in class, make sure if you do have a motor vehicle collision and the airbags have not went off, that you protect yourself because they may be triggered while they're trying to work on getting the person extracted from the car. Do you see deformity of the windshield? We talked about spider web of the windshield. That is an indicator that they've suffered a head injury. Deformity of the helmet. Remember also with the windshield comes the deformity of the steering wheel also. Look for indicators of the mechanism of injury and consider how the MOI produced the injuries expected. A lot of times the mistakes that new EMTs make as they enter out into the field is they get this tunnel vision. They start paying attention to only what they see that's the most distracting thing, and they forget to kind of check out the environment for clues. It's always important to kind of remember that because your mechanism of injury can kind of guide you into the things that patient may be suffering from that you may not see externally. Focus on identifying and managing any life threats. I guess this is becoming as commonplace as talking about ABCs and oxygen. Make sure you manage the life threats. Form that general impression about what's going on with that patient today. Look at the chief complaint. Confused, slurred speech, repetitive questioning, or amnesia is an indicator that there is a head injury. If the patient is unresponsive, You may have to get information from the bystanders or family members. An MOI that suggests a potential spinal injury should lead you to provide complete spinal motion restrictions. So that means that we're going to put them in a C-collar and a CID on a backboard, and we're going to completely immobilize and pad our voids and protect that patient from further damage. Airway and breathing. Use jaw thrust to open the airway if they're unconscious. If that jaw thrust is ineffective, use the head tilt chin lift maneuver. Be very careful. You do not want to turn the head and cause paralysis. But what is more important, breathing or paralysis? They want you to always use the jaw thrust maneuver first. Vomiting may occur in the patient with a head injury. Apply a cervical spinal immobilization device. Move the patient as little as possible and as carefully as possible. And oxygen is always indicated for patients with head and spinal injuries. Your pulse oximetry should be maintained above 90. This is a number that varies from one textbook to the next. Most say at least 94. Circulation. A pulse that is too slow in the setting of a head injury can indicate that their condition is very severe. Single episode of hypoperfusion in a patient with a head injury can lead to significant brain damage and even death. So it's always important that we try to maintain perfusion to the brain and watch for any signs and symptoms of shock and control bleeding as we can. Your transport decision, reduction of on-scene time and recognition of that patient being critical is going to increase their chance of survival. It's always important early on, if you see that it's going to be a long extrication time, maybe it's appropriate to call for that helicopter to come and do air evacuation of that patient, because by the time that they can do their pre-flight checkoff, which is approximately 20 minutes, and then their flight time to you, usually we can kind of get them extricated from the vehicle and be just in time for that helicopter to get on scene. So that may be something you want to consider as well. Provide them with a patent airway, and high flow oxygen is absolutely paramount, and suction should be ready because they do suffer nausea and vomiting periodically. Maintain that spinal immobilization. If they should vomit while they're on the backboard, remember you turn them on their side with the backboard as a unit in order to kind of help get the vomit out and have that suction there to assist you. History taking. Obtain a medical history. Be alert for any injury-specific signs and symptoms as well as pertinent negatives. Using your OPQRST may provide some background on isolated extremity injuries, onset, provocation, quality, radiation, severity, and time. Gather as much sample history as you can while preparing for transport. During the secondary assessment, instruct them to keep still, not to move their head or neck. Perform a full body scan using the DCAP BTLS and examine the head, chest, abdomen, pelvis, extremities, and back. And of course, you should have checked the back prior to putting them on the backboard, because once they're on the backboard and in the back of your truck, you're not going to be able to check it again. Check perfusion, motor function, and sensation. Pulse, motor, and sensory is the way we always say it. In the extremities prior to moving the patient. It's really critical, particularly on skill stations for national and even in the field, that if you're going to immobilize them, you check for pulse, motor, sensory before and after you have them on the backboard or whatever item you're using. If it's an isolated extremity fracture, you want to check pulse, motor, and sensory before applying the device and then after you've applied the device. A decrease in level of consciousness is a very reliable sign of a head injury. Look for any cerebral spinal fluid or blood. Check the pupils. Pupillary response, remember, if they're unequal or sluggish, gives you an indicator that there's a problem with the brain. Do not probe an open scalp laceration with your glove. Perform a neurologic exam. Remember your Glasgow-Coma scale. EVM 456 is the way we've always remembered it. Eye, verbal, motor. A good score is a 456. Always use simple and easily understood terms when repeating the level of consciousness. There's your Glasgow-Coma scale. Remember EVM 456. It's your best score you can receive. Spinal injuries. Inspect for decap BTLS and check the extremities for circulation, motor, or sensory problems. If there's impairment, note the level. If they tell you, well, I have numbness and tingling in my pinky fingers on both sides, that's important to note that. Put that in your documentation and report it to the receiving facility. They can actually determine what nerves are being impinged based on what you tell them. Pain or tenderness as you palpate the spinal area is a warning sign. Vital signs. Significant head injuries can cause the pulse to be slow and the BP to rise. Respirators will become erratic. Pupillary size and reaction to a light can be adjusted a little bit as a result of the head injury. Remember, pupils will become uneven or unequal, and use your monitoring devices. It's always important to call for an ALS provider. Repeat the primary assessment in your reassessment. Reassess your vital signs. Reassess the chief complaint. Recheck your patient's interventions. These injuries can suddenly affect the respiratory, circulatory, and nervous system, so you always want to reassess your head injured or spinal cord injured patients at least every 5 minutes. They're considered. You must act quickly to evaluate and treat these patients if cerebral spinal fluid is present. Remember, you cover it with sterile gauze, but do not bandage it tightly. We're allowing it to drain freely. Hyperventilation should be used with caution. Some old school said that you needed to hyperventilate in the case of a head injury. That's no longer necessarily recommended. It's very dependent upon what you're doing. And administer a high flow oxygen and apply a cervical collar. Your documentation should include the history you obtained at the scene, your findings during your assessment, what treatments you provided, and how the patient responded to them. And make sure you document your vital signs for unstable patients every 5 minutes and stable is 15. 3 general principles when it comes to managing a head injury is make sure you establish and maintain an adequate airway, control bleeding, provide adequate circulation to maintain cerebral perfusion. If that patient goes into cardiac arrest, start CPR and follow your standard precautions. Assess the patient's baseline level of consciousness and continuously monitor for any changes, good or bad. When you're managing the airway, it's important to establish that adequate airway by using the jaw thrust maneuver. Once that airway is open, maintain the head and cervical spine in a neutral inline position. Here are some examples of maintaining a neutral inline position until we get the cervical collar in place. It's always important, too, to work with your partner and make sure you keep that open line of communication as you're doing the skill. This is something we'll be practicing in class. Managing the airway, you want to make sure you remove any foreign objects, secretions, or vomitus. Make sure a suction unit is always available. Check your ventilations and give high flow oxygen to any patient who has a suspected head injury. Begin CPR if they're in arrest. Active blood loss will aggravate hypoxia, so you want to control any bleeding. There is a thing called Cushing's triad, and it's where you have an increase in blood pressure or hypertension, a decrease in the heart rate, also known as bradycardia, and irregular respirations. These are your Shane-Stokes respirations, or also known, there's another set called central neurogenic hyperventilation or BIOS. Follow your standard precautions. Maintain the patient's airway while keeping the spine in proper position. Assess your respirations. Give supplemental oxygen. You're still maintaining your... After you open the airway, consider inserting an oropharyngeal airway. Have a suction unit available. High flow oxygen. This is for your spinal injuries. We always want to make sure that we immobilize the head and trunk so that bone fragments do not cause. Assess pulse, motor, and sensory, and remember we're going to do that not only before we immobilize, but also after. And assess cervical spine area and neck. Never force the head into a neutral inline position. Supine patients secured to a long backboard. The ideal way to move a patient from the ground to a backboard is the 4-person log roll. It's a skill we'll learn in class. You may also slide the patient onto a backboard using a scoop stretcher. Seated patients. If you have time, understand this is if you have time and they are not a critical patient. Critical patients, you use a rapid movement of getting the patients with spinal precautions taken as much as possible. But if they're in the seated position and time allows, you can use a short backboard to immobilize the cervical spine and the thoracic spine. Then secure the short board to the long board. The exceptions include situations where you or the patient is in danger, you need immediate access to other patients, the patient's injuries justify urgent removal, and just so you know, the reason why I had this last interruption is because my husband decided to come in and attempt to distract me during this lecture, so I apologize for the pause. But if you have a standing patient, this is going to require 3 EMTs, and we'll talk about how to do that skill in the classroom where you can actually immobilize them from a standing position. Some of the things I've seen that have happened is the providers that become complacent end up just telling the patient to walk over and get on the cot, and that's never a good thing to do. If a person is truly been involved in a serious motor vehicle collision, they may be up moving around. The adrenaline is pumping. They may not know they're injured. Cases have been seen where patients have suffered severe cervical injuries. They've gotten out of their car, they've walked around for 2 or 3 days. 2 to 3 days later, they turn their head the wrong way and they end up going into paralysis. So make sure you utilize immobilization devices properly. Cervical collars are going to provide preliminary and partial support. They should be applied to every person who has a possible spinal injury, and it must be the appropriate size for the patient. This is another skill we'll be discussing. Short backboards, these are some examples of those out there. They're a vest-type device, rigid board designed to stabilize and immobilize the head, neck, and torso in the non-critical patient position. Long backboards, of course, are going to provide full body spinal immobilization. This is the best way to get quick immobilization taken care of. Honestly, you're probably not going to be seeing a lot of wooden backboards out there anymore. They're no longer advocated as much because of the chance that blood and other fluids can absorb into the wood. So this is not probably a common backboard you'll see, but you can see the plastic device sitting right next to it. Helmets. If a helmet fits well and prevents the patient's head from moving, it should be left in place, provided that there is no impending airway or breathing problems, it doesn't interfere with your assessment and treatment of the airway and ventilatory problems, and you can properly immobilize the spine. Remove the helmet if it makes assessing or managing the airway problems difficult, if the helmet prevents you from properly immobilizing the spine, if the helmet allows for excessive head movement, or if the patient is in cardiac arrest. The preferred method it usually takes 2 people, and it's good to consult with medical control about your decision to remove a helmet. We will go through the steps for helmet removal in the class. The advantage is that it allows the helmet to be removed with application of less force, therefore reducing the likelihood of motion occurring in the neck. Disadvantage is that it's more slightly time consuming. This is an alternate method that we will also discuss in class. I know it's a little vague here. Just alternate method, you're removing the chin strap, the face mask, the jaw pads, placing your fingers inside the helmet, hold the jaw with one hand and the occipital with the other, insert padding behind the occiput. This is an alternate method. It takes a little bit of time, but we will discuss it. We will show you in class. Typically, the person who is at the side of the patient's chest is responsible for making sure that the head and neck do not move during the removal of the helmet, and children may require additional padding in order to maintain that neutral inline position. All of these are skills we will discuss. It's good to have you guys reviewing this presentation. If you have any questions as you went through the dialogue, please make sure you write them down so we can discuss them in class before we begin the skills component for this particular lecture. I'll look forward to seeing you. Have a good evening.